This next slide talks about tidal volume, and it asks the question, you have a 5'3" female weighing 110 and a 5'3" female weighing 150, whose lungs are bigger? Hopefully you would say their lungs are the same size, because they're going to be. It doesn't matter if, I'm 5'3", if I weigh 110 or if I weigh 210, my lungs are going to be exactly the same size. So that's why we do the ideal body weight. We don't do the actual weight. And the next slide, it says to use a tidal volume of 8 to 10 mLs per kilogram of ideal body weight for COPDers. Do not do that. That is stupid. Don't do it. Their lungs are already overinflated enough. We do not need to stretch them out even more. It's an old theory, and what we do is we give them PEEP to make up for their auto PEEP, their air trapping that they already have. So hopefully you said, I disagree with this, because it's don't do it. It's very old school. There is concern over using a smaller tidal volume, but again, that's what PEEP is for. We don't need to give them a high tidal volume and stretch out their lungs. And this next slide talks about tubing compliance. I talk about it because your book talks about it. We do the pre-use check on the vents in the real world. We don't do them in the lab because we don't have oxygen, and it will never pass. So we don't do it in the lab, but in the real world, you will be doing the pre-use check. When you do the pre-use check, it checks for tubing compliance. That stands for how much stretch does the tubing have. So if you've ever turned on a water hose and you might see it expand a little bit, and then when you turn off the water, it goes back down. Our vent circuits do the same thing. And some patients lose as much as 200 milliliters for every breath because that circuit is expanding, and then it goes down, and then it expands, and then it goes down. That volume in the circuit does not get to the patient. So we lose that. So that's what that's about.